So our landscape is changing, all the time. So typically we have different options I kind of put into buckets of, and these are non-clinical trial options. So our standard of care options offer both a fixed duration therapy kind of consideration, as well as what we call a treat to progression or continuous treatment option. Now, both are very good, right? So with CLL, not every patient is created the same, right? We use what we call molecular abnormalities, or what we call cytogenetic abnormalities, to sort of place our patients into different risk categories. And even so much as that they tend to show better efficacy with some of the drugs if they express, these mutations versus another set of mutations. And so when I see a new patient with CLL, I'll kind of sit down and talk to them with the different possibility options. So we have a group of drugs called covalent BTK inhibitors, and those drugs would consist of acalabrutinib, zanubrutinib, and our first drug ever approved in that space, which was ibrutinib. We also have a fixed duration option. Now we have another one I'm going to talk about in just a second, but we have a fixed duration option that's been available for a long time now. It's given for a total of a year, and that's including a oral drug called venetoclax, as well as an intravenous drug called Gazyva or obinutuzumab. So it's kind of an IV and oral combination. Now, some patients prefer that because they're done in 12 months. Other patients don't want to have to come in for IV therapy and have frequent lab monitoring, so they choose the all oral or pill option. But in those patients, it's kind of like having a chronic disease. They're on the medication for the duration, right? And patients do very well, and they're very well tolerated, but everybody kind of has what they prefer. Now, very new on the scene, we have a regimen that was recently approved, which was based on a trial that we first kind of put a lot of eyes on at previous year's ASH. The trial was called AMPLIFY, and it looked at the all oral combination using both acalabrutinib and venetoclax. So it used the covalent BTK inhibitor that I was telling you about, which is acalabrutinib, pairing it with venetoclax. And now you could also, if you wanted to, tie in the obinutuzumab, that IV therapy, for a triplet combination. But a lot of us have been focusing on that, all oral combination of acalabrutinib and venetoclax. Now, what was very big from this year's ASH was a huge trial called CLL 17, which got the plenary. And that was looking at ibrutinib with venetoclax. And we also know that we have the option of zanubrutinib venetoclax. Now that is based on a trial that's still ongoing, but that is looking at that combination too. So it looks like the covalent BTK inhibitors that I mentioned, the ibrutinib, the zanubrutinib, and the acalabrutinib paired with venetoclax, are going to be, kind of making their way into an all oral option for patients, also offering fixed duration. So we have the covalent BTK inhibitors alone, which you're on kind of continuously for, whether you stop it because of progressive disease, which we hope doesn't happen, or from toxicities. That's kind of what you're on, like a blood pressure pill. Okay. You've had the conventional combination of IV and oral, which was fixed duration. And now you have another option for fixed duration, which is the combination of the covalent BTK inhibitors with venetoclax. So, it's an interesting time to be a CLL patient. We used to have very few options, and now we have all of these possibilities to really offer personalized medicine and a personalized approach, for these patients with treatment naive CLL. Zanubrutinib has amazing efficacy by itself as a monotherapy. Okay. It very, very well tolerated, very good efficacy in that high risk population. I was mentioning how we use these cytogenetics, right? And so the one thing about zanubrutinib, because that population was not studied in the initial AMPLIFY study, was patients that have a 17p or a TP53 mutation, which are those high risk CLL patients, harder to treat, harder to respond. Now we get them to respond. It's not what I'm saying. They're in all of our trials. They're using regimens that were studied in all the combinations that I mentioned. But what happened with zanubrutinib monotherapy when it got approved frontline based on the Sequoia trial, that high risk population was included. And we saw that progression-free survival benefit and that response benefit with zanubrutinib monotherapy. Now, it's not it's treat to progression. Remember, it's not a fixed duration therapy, but in terms of efficacy, it is really good. Now, when you look at the combination of acalabrutinib and venetoclax, which is now a fixed duration option, the progression-free survival in that combination is also very good. Now, we don't have the data, though, on how patients with that 17p and TP53 mutation responded with that combination. We know how acalabrutinib does monotherapy with those higher risk patients. They do very, very well, but AMPLIFY did not include that population. So it's kind of hard. We can't really cross-trial compare. It's not the same patient population that's going on in the trials that got these drugs approved. What I will say is venetoclax does deepen the response. So continuous BTK inhibitors they're not a drug that's going to clear every clone of CLL out of your system. Now, can you have a clinical complete response, meaning on paper and on imaging, you have no measurable disease left? Absolutely. But if you were to actually look at the clones that remain in the body, you may still find some clones when you're just on a covalent BTK inhibitor alone, like acalabrutinib or zanubrutinib. When you add in obinutuzumab, the IV therapy, or venetoclax, you have a chance to clear those clones. So you deepen the response. A lot of us talk about MRD or minimal residual disease. You can take that positive and turn it negative. So you can actually at the clonal level clear the clones. So that is how we kind of look at the benefit of maybe a doublet compared to monotherapy. But those patients who are on monotherapy with zanubrutinib alone, they do great. And they're not necessarily worrying about the clones in their system, right? We tend to want to clear every last bit, but they can live years, with just being on monotherapy. It just depends on what type of response you're going for, and the disease characteristics. I am a cell therapy doc. I love bispecifics. I do like the idea of CAR T and CLL, although it has not performed overall as well by itself as we've seen with some of the other drug combinations I just talked about. So I think looking at bispecific combinations, so there's a non-covalent BTK inhibitor that's moving its way up in lines of therapy called pirtobrutinib. We have BTK degraders that are being studied by several companies that look great. So I think we're going to start seeing degraders come up, third line, second line, and they're going to be paired with another drug. The other thing that is coming out is that we have a next generation of venetoclax. It's a drug called sonrotoclax that I actually was very fortunate enough to have a frontline study here with that drug in combination with another drug, and that looks very, very promising as well. So I think we're going to see, I guess I shouldn't say completely new novel ideas. The BTK degrader would be a new novel idea, but I think we're going to see an improvement on the classes of drugs that we've already been working in. Okay, so I think we've come so far just in the last 8 years, 5 years, 3 years with CLL that it's going to be even more exciting. Like I mentioned, degraders, we have pirtobrutinib available now, earlier lines of therapy. We're going to have, I do think we'll have some combination with bispecifics, potentially maybe we'll even do some type of pairing with covalent BTK inhibitor and CAR T. So there's just so much out there, and where it lands, it's going to make it really fun to choose your treatment selection. And now we're going to be arguing sequencing even more so the way that we already do in follicular and DLBCL. So it's, no one wants to have cancer, right? But I always tell my patients, like, we have so much coming out in the field of lymphoma and CLL that, the opportunity for amazing therapy and, clearing your disease is getting even better and better. So it's an exciting time.